Good morning, everybody. This morning we're talking about diabetes, and the chapter in Edinger is management of diabetic patients with diseases that require corticosteroids or would typically be treated with corticosteroids. And I guess from a clinical perspective, I want to kind of take that back to something that's a little bit more applicable and talk about management of diabetes with Cushingoid patients as well, just because I think we see that more commonly than, well, probably equally commonly with other diseases. But I think when you've got a choice to add in corticosteroids, it's much more controlled as opposed to when you've got Cushing's and diabetes. Is that all right with everybody? Excellent. And it was did anyone read the chapter? Yeah.
Briefly.
Well, there wasn't much to read, really. They didn't go into much detail about anything. They've got a nice kind of algorithm in there where if you're ever in a situation where you've got a diabetic patient and you would typically treat something that they've presented with corticosteroids, there's a nice kind of thing to follow. And something that I did find interesting is that in the human world, they've got really good consensus statements and guidelines about when to use corticosteroid-based medications in diabetic patients and what to look out for, which would be really nice for us to have. And that kind of algorithm is built off the human recommendations. So it's maybe a nice reference to have in the back of your mind, like if you're ever in doubt. But I didn't find the chapter very helpful other than that. Sorry, one sec. Excuse me. So first thing I wanted to cover when I finish sneezing is what does cortisone do to our kind of metabolism of fats, carbohydrates, and protein? Because I think having that kind of in the background of what we're going to talk about in the context of diabetes will just help if we've got that really fresh. So can anybody tell me what the effect of cortisol is, increased cortisol levels is on carbohydrate metabolism?
It I guess in glucose, we see more gluconeogenesis.
Good.
See more glycogenolysis, I think. Mm-hmm. Right. Yeah, like everything driving more towards more glucose in the blood. So I guess.
Oof. Sort of. What happens to the liver with dogs on cortisone?
They have more storage of fat.
Yes. And? What else do they store?
It's probably going to be glycogen.
It's glycogen. It's glycogen.
But
so
yeah.
You're exactly right in the gluconeogenesis side of things. So I think of cortisone as the hormone that is designed to prepare you for a disaster. So if you sort of think of it as the stress hormone, and what the body is doing is putting all of your energy reserves into the most accessible form. So protein is inaccessible. Like if you're trying to get energy out of muscle, if all of a sudden your food supply drops off, if you're trying to get energy out of muscle, it's going to take a really long time and it's going to be very costly energetically. Whereas energy that comes from pure glucose is very efficient, and energy that comes from glycogen is the most efficient way for you to get energy. So in terms of carbohydrates, gluconeogenesis for sure, but cortisol actually increases the new glucose that you formed in storing that as glycogen, and it stores it in the liver because that's the most accessible place that they can just mobilize it. You can just mobilize it as soon as the food supply cuts off. So gluconeogenesis, what does that mean?
It's also done in the liver, and it's basically when molecules are converted. I think it's like pyruvate and all that converted to glucose, but it's been a long time since I've looked at that.
Sorry. I know, I'm getting really deep here. Sorry, this is why I wanted to review it, because it's really nice to have it.
Anyone
Like,
else?
you got to go through this about 400 times to have it clear in your head. So pyruvate stuff, yep, molecules turning into glucose. Where does the original molecule come from? If you've got cortisol excess, usually. I haven't worded that question very clearly. What do we get loss of with Cushingoid patients? Muscle, fat, or
Muscle.
Yeah, muscle, exactly. So typically gluconeogenesis is a product of conversion of amino acids to glucose. And the amino acids may be dietary, or in the case of cortisol excess, we get breakdown of muscle and prioritizing gluconeogenesis from those amino acids. So that's you kind of picture your Cushingoid dog, you know this. But yeah, that's what happens to carbohydrates simply with cortisol excess, gluconeogenesis from muscle breakdown, and increased glycogen storage in the liver, causing hepatomegaly. Okay, let's go into protein now that we've started. And we've kind of finished, because that's about the whole story. So can someone summarize what happens to protein with cortisol excess?
Gets catabolized.
Good. That's a good word.
Yeah.
Yeah. Into
a more readily available energy source, glucose.
Yeah, good. So catabolized to amino acids, like broken down to amino acids, and then utilized in the process of gluconeogenesis. So if you were writing an exam answer, I'd say half a mark for that.
Oh yeah, I kind of took a big shortcut, didn't I?
One important pathway there. Okay, let's go on to fat. What happens to fat with increased cortisol levels? What's the classic Cushingoid presentation?
Pot-bellied, so you get more storage, and that's mostly, I think, because of the liver becoming fattier and bigger, and because you're losing muscle as well, they have thinning of their abdominal muscles and they look kind of more pot-bellied. But yeah, I think there's just generally more fat mobilization.
Good. So fat mobilization. Where does the fat come from?
Like extremities. It's not.
What happens to appetite in Cushingoid dogs?
Increases.
So we've got increased intake, typically, of fatty acids. And then we've got increased lipolysis. But also, I should say, there's increased lipoprotein lipase activity, so increased breakdown of fats, lipase being the enzyme that breaks down fats. But there's also increased storage of fats viscerally, because those fats are more easily mobilized than fat that's stored in the extremities and things. So where the fat is stored in the kind of abdomen, but also in the, Josh, you said it before?
Liver.
Yeah, liver, exactly. So we've got increased fatty acids in circulation, we've got increased fat storage in the abdomen, and then we've got increased fatty acid storage, triglyceride storage in the liver. So we've got lots of different sources of energy from fat. Do you know, let me see. Let's now talk about insulin, what the effect of insulin is relative to cortisol on fats. So let me just work out a way to word this. So what is the effect of cortisone on insulin's activity?
It antagonizes insulin activity.
Good. At what level?
Is it at the receptors? The insulin
Yeah.
receptors on the cells?
Yeah. And what are the main tissues that have insulin receptors?
I thought it was everything, really.
So is the brain dependent on insulin to get glucose?
No, not brain and heart.
Yeah.
So every other tissue.
Two big ones.
Muscle,
Mm-hmm.
probably fats,
Yes.
and I guess other viscera.
Mm-hmm. Muscle and fat are the two big ones. So remember there's lots of different GLUT channels, G-L-U-T, capitals.
Yeah.
GLUT4 is the channel that's activated by insulin, and GLUT4 are predominantly present on muscle and fat. So most other cells can get glucose through the other transporters, whereas muscle and fat are quite dependent on insulin for accessing energy. So what is the effect of cortisol on the insulin effect on muscles specifically?
I guess, your muscles are getting less glucose as an energy source.
Good. Excellent. And fat?
I guess the same, but also, is there an impact of storage there? I've never quite thought about it.
Yeah, so I think this is really interesting. So in muscle, cortisol will decrease insulin activity. In fat, it almost increases it. So actually steers you towards a muscle catabolism and storage of fat. So it puts all the energy into fat storage rather than into muscle building. Makes sense?
Yeah.
Interesting, hey?
Yeah. No, yeah. Hadn't really thought about that too much.
Yeah. Okay, so there's lots of different causes of insulin resistance, not just cortisol. What in a normal healthy animal, say you've got like a stressful time, or concurrent disease, most animals don't get hyperglycemic as a result of the insulin resistance caused by just kind of increased cortisol levels. And in fact, most animals on prednisone don't become hyperglycemic because of insulin resistance. What stops that hyperglycemia from developing? What is that mechanism in healthy animals to overcome insulin resistance?
So, isn't it just more insulin?
Yeah, exactly.
Yeah.
Exactly right. So the beta cells just work harder, essentially. So in what, obviously we're here to talk about diabetes, so in what disease state do the beta cells, are the beta cells unable to upregulate insulin secretion?
I guess if they get to a point where they're fatigued, like in a type 2 diabetic.
Yeah, exactly. Beta cell exhaustion.
Like a relative insulin deficiency.
Mm-hmm. So the answer I was looking for is diabetic animals, basically, pre-diabetic animals. So let's talk about dogs and cats a little bit separately here because the mechanisms are quite different. In a dog, what mechanisms are there of insulin being insufficient? What causes diabetes or susceptibility to insulin resistance?
I think it's more autoimmune in that it's destruction of the islets. Type 1 is the example in humans.
Yep. What about
also chronic pancreatitis, I think, like in
good.
dogs.
Excellent. So inflammatory diseases of the exocrine pancreas can result in beta cell dysfunction. So that's just an important one to have on the list. And what about, say I had an entire female dog who developed sudden onset PUPD, which seemed cyclic and would resolve intermittently.
It's
What would you-
estrogen is causing the problem to resistance.
Profound insulin resistance, yeah, exactly. So that recurrent insulin resistance. Is it estrogen?
Oh, I was
Progesterone.
guessing.
Progesterone. I think it's
I think
progesterone.
it's progesterone.
Yeah, same. I should have looked this up, but I think it's progesterone. But there's a cyclic insulin resistance that occurs in entire female dogs, and if they're genetically predisposed to like not having as many functional beta cells, then they might not have the capacity to compensate. There's another sort of acute onset inflammatory infectious disease that we can sometimes see diabetes with, which is associated with a high progesterone level as well. Entire female dog again.
Why?
Pyometra?
Pyo, exactly. Yeah. So sometimes we see insulin resistance and a lack of beta cell compensation with pyo as well. So there's sort of differentials for acute onset diabetes. But most of the time, as Josh said, we've got loss of beta cells due to immune-mediated destruction or previous chronic pancreatitis and severe atrophy and loss of functional cells. All right, what about cats? What might limit cats' ability? What is most commonly limit cats' ability to compensate for insulin resistance?
I think it's like a relative insulin deficiency in cats.
Mm-hmm.
So more, I guess, similar to type 2 diabetes in humans. So the islets become fatigued just from having so much insulin antagonism from insulin resistance elsewhere in the body.
Yeah, exactly. But at diagnosis of diabetes, most cats still have some functional reserve in their pancreas, in their beta cells, as opposed to dogs who are just out by the time you diagnose them, typically. What are the most common comorbidities that we see with cats with diabetes as the cause of their kind of insulin resistance?
Obesity.
Great. I reckon that's most common for sure. Come on.
Apparently,
Acromegaly?
it's ugly, but it's not really. We don't test for it as much as we
We
should.
don't test for it as much as we should. There's so much information coming out that just seems outrageous. But I think there was a paper that said that acromegaly is present in 30% of cats with diabetes or something
High percent.
crazy. Yeah. Okay, what else? What's a dog disease that cats get sometimes that's associated with diabetes?
You know, like Cushing's.
EPI?
I
You
mean,
mentioned
yeah.
EPI?
Hey, yeah.
Yeah.
So I've actually had 2 cats this year with hyper A.
Oh, really?
Yeah. And I've just been sort of called in to ultrasound them, and I've been clipping going, oh my God, this is a cat with Cushing's. The skin is like paper. And they're really pot-bellied and they're diabetic, and they've got quite a much better prognosis diabetes-wise if you can tightly manage the Cushing's. What else? There's another one. Dogs get it too.
Things like UTIs or any infections.
Good. Yeah. So any cause of systemic inflammation.
Yeah.
What's another cause of systemic inflammation, but also local inflammation that might affect beta cells?
Pancreatitis.
Yes. Yeah. Exactly. Pancreatitis. So cats with chronic or acute pancreatitis, are more likely to develop diabetes down the track just because of the beta cell loss and atrophy. But cats with acute pancreatitis often also have systemic inflammation and insulin resistance and can develop diabetes too. Has anybody heard about the new oral drug, which has been registered by the FDA for treatment of diabetes?
Yeah, the one that increases
Yes.
glucose like release through the urine.
Yes. Yeah. Very exciting. Has anyone heard any word from any reps or anything that might be on the way to Australia? No, me neither. I don't ever see reps anymore. I need you guys to tell me when new drugs come out.
Yeah, it's super interesting, but it sounds really I don't know, kind of counterintuitive. Like it would cause more PPD and those diabetic signs we're trying to manage. But I think the papers that came out didn't really say that. It was pretty, yeah, it was interesting.
Yeah. So do you want to explain the mechanism of action?
I don't remember. It was I can't remember. Sorry, but it just basically means more of the blood glucose is put into the urine, so you're effectively lowering your blood glucose. So you've got that controlled, but at the cost of, I guess, having glucosuria.
Yes. So most glucose, as you know, the glomerular filtration barrier does not filter out glucose. The glucose is reabsorbed in the proximal tubule by, I think it's a GLUT2 channel, just non-insulin dependent. So what it does is blocks that channel and means that all the glucose that's gone through into the tubule, and don't forget, kidneys get 25% of every heartbeat of blood flow. So that's a lot of glucose that is potentially then excreted and not able to be reabsorbed. And then it just comes out in the urine. And that's an interesting point that Josh raised about the exacerbating polyuria, which will for sure. But if it means it's once a day, if it means that we can avoid insulin and glucose curves and all of those things, then it's definitely going to be better for the cats.
Yeah, and like I think there were two papers that I've seen that came out this year, and they like did those kind of quality of life scores, and the owners all reported that like they were better. So it didn't, it weren't like, oh my God, my dog's PPD and wetting the bed, that kind of stuff. So it was, okay. That was my main concern initially.
Yeah.
But
is it registered for dogs as well?
Don't know. Sorry.
I don't think so.
It's really interesting that then the danger of insulin is hypoglycemia, obviously, and you know, cats like are more likely to go into remission than dogs, much more likely to go into remission than dogs. And all of a sudden, the insulin requirement is 0, and you've got to be doing constant curves to detect when that happens. It's interesting that this is almost self-regulating. Like if there's no glucose in the urine, it doesn't do anything. So it's a nice safe option for management if it works.
Yeah, I think one other thing that was a problem was I think it can cause DKA as well, like a normoglycemic DKA.
Oh wow!
Because normal hypoglycemic DKA, because the glucose isn't going as well, because you haven't got that.
Still don't have insulin.
So it's not going into tissue, so you still get ketoacidosis to some degree.
That's very interesting.
Yeah, it was.
I think you're supposed to use that drug only in like eating, drinking animals, so not like animals who come to us like with sick and on DKA. Yeah. Like we don't use. I think this was my understanding, but I'm not sure.
Yeah.
There's a specific cohort you would not use that drug at least initially till you stabilize them.
Yeah.
Yeah, but even for, I guess for like chronic patients, I think some of them were getting DKA because like as an outpatient.
And
blood glucose is normal.
It's not. Yeah, it's not. They'd get it particularly if they're polyuric. If they feel a bit yuck and they stop drinking, they're going to get dehydrated really quickly, and then they're going to get. I guess they don't have the hyperosmolar bizo, but yeah, that's a really interesting point. They could get acidemic quite fast with the decreased perfusion and dehydration and stuff. Cool. Okay, so that's kind of all I wanted to cover as far as kind of background pathophysiology of diabetes and Cushing's. I thought let's talk about when we've got a patient that presents middle-aged, female, neutered, Westie, who making it up as I go along, who presents with PUPD. and on blood tests has a glucose of 24 and glucosuria, concurrent glucosuria, no ketones, well dog, eating well, obese body condition, but weight loss recently, and an ALP of 1500 and an ALT of 700. What's your approach to this patient going to be?
In this one, I probably would recommend an abdominal ultrasound, just to query the liver values and see if there's something there that is either potentially antagonizing glucose metabolism or homeostasis.
Yeah. Can you diagnose this dog as diabetic on the findings you've got so far?
No. I guess you could do a fructosamine to try and increase your suspicion. You could also put a freestyle on and see if that is a consistently hyperglycemic animal. If it's concurrent, if there's other, I guess they get a better history about what the signs have been like recently. There've been weight loss, because they've been PUPD for a while, those kind of things.
Yeah.
Just to try and increase my suspicion overall.
So in your abdominal ultrasound, there's no evidence of active inflammatory disease. There's no pancreatitis or anything. No pyo, no uterus, in fact. There is hepatomegaly, and the liver is bright, but smooth in echo texture. And there's mild bilateral adrenomegaly. What do you do? And the glucose is persistently elevated. So you do another couple of spot checks and fructosamine's elevated.
Do a low dose dex test then.
Do you?
The thing is, if you're not going to, if you're suspicious of Cushing's, and if you don't control the Cushing's, your diabetes is not going to, like, whether the diabetes is there actually, or is it just because Cushing's is uncontrolled? Like, you need to control the Cushing's to get control of diabetes, if there is diabetes, we're saying.
Yeah. I think at this point we can say this dog's got diabetes.
Yeah.
If we've got persistent hyperglycemia and glucosuria, with no evidence of kind of active inflammatory disease, which might, like pancreatitis, which might be causing temporary beta cell failure, I think we can say it's diabetic. What are you laughing at, Josh?
Oh, Toots is being really cute.
Oh.
Sorry.
Groaning in the background. This is so boring. Oh, it's all right, man. Yeah, so I think we can say he's diabetic. And I'm going to just put a bit of a disclaimer here. We're going to talk about how you manage diabetes and concurrent comorbidities, and this is so subjective. There's no guidelines around this. I'm going to give you my opinion because I feel like that's what you're here for, but you're going to get different opinions from different specialists, and different cases are going to be managed differently, obviously. So I just want to sort of prompt discussion and make sure everybody understands the kind of background and what impact you might be having by introducing corticosteroids with diabetes. But in terms of managing Cushing's and diabetes, I don't think I've ever ultrasounded a diabetic dog and been able to say this dog doesn't have Cushing's definitively, because diabetes causes a lot of stress, physiologic stress, and it causes fat storage in the liver. So the livers are always bright when they're uncontrolled diabetics. They're always big. The adrenals are always hypertrophied because there's been increased physiologic demand on them. So I think whilst the ultrasound is really important to rule out that pancreatitis or something like that as a comorbidity, I don't think it helps you differentiate between the two diseases. At the moment, we know that diabetes is present, and we know that our Cushing's tests are probably going to be positive because we have increased physiologic demand for, like, physiologic cortisol. Does that make sense? And we've got adrenal hypertrophy. Like, we've got a kind of appropriate Cushing's when the dog is physiologically stressed. Does that make sense? Yeah,
normally with these ones, I kind of send them all get them controlled, send them away, and get them back for
Testing.
adrenal axis testing.
Yeah. And how long would you give it? Like how long?
I guess it depends how hard it is to control, but yeah, a month probably.
I think probably a month is a minimum to get that, because the adrenals are hypertrophied. They've got increased capacity, and it's going to take a while of decreased stress to get those adrenals to shrink back down and have our then adrenal axis testing be accurate.
And then by then you might have a feel as well if you're getting, resistance as well with your curves. If they're really stubborn, then you might be like a bit more suspicious.
Yes,
well.
completely agree. What dose of insulin is considered insulin resistance?
It's greater than 1 unit per kilogram.
Yeah, some references actually say 1.5. It's quite high. Like if you're kind of giving 15 units to a Westie, so it's quite hard to get resistance. So in these patients, I kind of say, look, what we're going for in our initial management is to just bring the glucose down, get the weight stabilized and minimize weight loss. We're not looking for tight control, but the tighter the control we can get, the better. So it's really nice to have a glucose sensor on these guys and adjust the insulin dose as needed. And then in a month's time, get them back in for adrenal axis testing if it's still showing evidence of PUPD despite control of the glucose levels. Is that everybody's happy with that?
Do you do an ultrasound in a new diabetic in a dog? I don't know if I've ever done that. Looking for a primary cause. Is it just pancreatitis you're looking for?
Yeah, pretty much. Yeah. The times when I do it is when the blood tests are a little bit weird. So say the renal values are up a little bit, or that like ALT is way higher than I'd expect to just process or something like that.
That was probably the only reason in this case I would, but
yeah. Most diabetic dogs will have an increased ALP and ALT just because the liver's under stress. Not the liver's not under stress, the liver's storing more and there's increased hepatocellular activity. And when the liver gets that enlarged, you do get a little bit of intrahepatic cholestasis just because the cells are swollen and full of lipid. Good. So that's kind of how I would manage a new onset Cushing's with diabetes with Cushing's, working up the Cushing's. What about in a cat? If you have a cat that you're suspicious of Cushing's, I would have said, don't worry about it, never happens, but twice this year. Would you do the same approach? Yeah, same. So most of the time with cats, you diagnose them. You don't usually do an ultrasound like Bronzed. So you've kind of, most of the time when we're seeing cats and being suspicious of acromegaly or Cushing's is when we've like given them all the insulin and their curve just stays like up here. It doesn't go anywhere.
If it's like skin is peeling off though.
Sorry?
The skin is peeling off. I'm just wondering, like, I've never seen like one of these before, and it's I wonder if, like, I can see myself being a bit like, oh my God, I need to do something, but
yeah.
So would you still kind of just wait and see? Because I just imagine, like, yeah, I guess most diabetic cats don't present with their skin peeling off.
No, exactly. I reckon the skin thing I really was conscious of because I was clipping the cat. But I think you could just think they were sort of pot-bellied because they're quite well furred over their tummies, aren't they, as opposed to dogs. So you don't see that sort of skin change. And I have to, like, every cat I've ever seen with Cushing's, I've seen because of diabetic, like insulin resistance and inability to control the diabetes. So they've almost always, you've kind of already done the diabetes management as best you can, and then you need to do the Cushing's diagnosis. How do you test for Cushing's in a cat?
Yeah, it's low dose text, but it's actually the dose is different. It's
Good.
not the same dose.
Very important to make sure that you check, the test protocol, because the dose of Dex is 10 times higher in a cat. for a low-dose dex. And a low-dose dex is more sensitive and specific in cats than an ACTH stim test. If I got that right, sensitive and I think it's better all round. Let's just say that without being too specific. Than an ACTH stim test. So that's the way that I'd work that out. And then if it came back positive, then we would look at treating them. Cushing's. What about the other more common acromegaly? How do we diagnose that?
Check for IGF-1.
Good. Excellent. What do they look like clinically? A really bad one.
So acromegaly is a syndrome, like you have the physical changes, but if it's just hypersomatic and they don't still have the syndrome, then it's just essentially uncontrolled diabetes is what you're.
Yeah. So
that's
often
what
they
we should
look
check.
completely normal. If they have the syndrome, what do they look like?
They'll have a broad head. Paws will be really big. The dentition, something change, like it's whatever it's called.
Yeah. I can't remember what it's called.
Prognosis
Their teeth
or
go further
something.
apart.
Yeah.
Their incisors go gappy. Yeah. Good. So yeah, big lower jaw, brachydontianism, is that what that's called? Yeah. And dentition, yeah, the teeth go further apart. And they're just huge. They just look like big, mean cats. And sometimes I ask clients to show me a picture of the cat from a few years earlier, just to help. Excellent. How do you treat it?
If you do surgery, that's good.
Good, yeah.
Otherwise, is it pasirotype?
Yeah, nobody does it though. So expensive, impractical. Yeah. Octreotide, is that what you said?
Octreotide.
Yeah. It's a somatostatin analog, which apparently blocks the effect of growth hormone. But yeah, nobody does it. The studies that I've sort of seen are sort of said showed good response, but access is very limited, and the cost and logistics of giving it are quite demanding. Have you ever seen it used, Josh?
No, I haven't.
No. Have you ever diagnosed a case? Hypersomatotropism?
No.
Had one recently that went for surgery, and it's doing so well. Like, it's really, yeah, really rewarding. No complications from surgery, just smooth as, just put a little bit of suction on that pituitary and suck it out. It's amazing. And they're tiny, they go through the cat's mouth. Like, how do they even get in there? It's phenomenal. Anyway, that's a surgery thing. We don't need to talk about that.
And you check if the insulin-resistant diabetic cat looks completely normal on physical exam. You would check for acromegaly before you go looking for hyper A.
Yeah, for sure. Absolutely. Yeah. Hyper A is so rare in cats, and actually acromegaly can cause adrenal hypertrophy and therefore hyper A. So I would actually look for the acromegaly first. Yeah. And it, I was going to say I think Cushing's can cause a false positive or increase in the IGF-1 as well, but I probably should confirm that before I say it on a platform where people take my advice. Nobody listened to that part. I wish I had an editor. In every department of my life.
Me too.
Yeah. Okay, so let's talk about when we've got a diet, or does anybody have any cases they want to talk about? Diabetic patients with comorbidities that they struggle to manage?
I guess the main thing I would be interested in is you're looking for you're still going to see insulin response on a curve. You're going to see that the insulin's working. You're just at a dose which is ridiculously high.
Sometimes you get no response whatsoever.
Right.
Yeah.
And you just don't
flatline. Yeah. Okay. Because in cats often we're using long-acting insulins that aren't really designed to like dip as well. They're designed to just lower the whole kind of curve. So you still just got this straight line and it's still over 20 all the time.
Are you using Toujeo at all? Like, does anybody have experience with Toujeo?
Josh, I think probably more so than me. I just
Yeah,
say
use it a little bit.
In
Yeah.
dogs as well, or just you're using
Dogs,
it?
dogs and cats. Yeah.
Because I have not, like, I know of it, but I've not personally used it yet. So I don't, like, I feel a bit scared about it.
Don't be. It's fine. Just glargine.
Is it, yeah, are you finding any difference in mechanism, like in activity relative to glargine?
I mean, all the ones I've used so far, sadly, have had to, like, have gone back to the referring vet for long-term management. So, and I'm kind of like, how's it going? But the initial kind of induction of it was always quite promising in a lot of them. So, I think Liz has got a couple as well, and she's had some success in a dog and a cat. And I know Jodie was using it a bit as well. I think she was one of the first I saw using it, and was doing. She had some success as well, and as she said, it's the future. So
yeah, interesting. What's the difference?
I think the idea is that, I mean, I think this is from Linda Fleeman's kind of input on it, but because it's a higher concentrated glargine, the smaller surface area is meant to absorb slower, so you get a slower release of a basal insulin. So it's a good one to use for like your basal part, particularly in cats, but you can use it in dogs as well, and sometimes combine it with other more kind of short acting. But
that's interesting. So you can almost, because can insulin is 70% long acting, 30% short acting. And you know, some patients, you give them the can insulin and the curve dips right down, and then it like goes back up again, and it just doesn't last long enough. But they respond really well to that short acting part, but the long acting part just isn't sufficient. So if you're using a combination of, how do you say it?
Toujeo.
Toujeo or Toujeo, I don't know.
If you're using a combination of that as the long acting, and then like a 20% short acting, like Actrapid or something like that, it's interesting to be able to play with that ratio a little bit more.
Yeah, I really want to play with it more.
Yeah.
Not had much.
Long term. Nobody wants to play.
Yeah.
Josh, have you just seen it used as a baseline combined with a short acting in dogs, or ever on its own in dogs?
I've not had one where I've used the two, but I've seen other people. I think Liz has got one at the moment. She's using two. I think I can't remember. She's using something else. I think, yeah, I'll be guessing. But the ones I've used it in have just been like on its own, and you can get away with once day dosing with this one sometimes. But from what I've seen, pretty much all of the patients so far have gone to twice day, and ultimately,
Good theory.
Yeah.
Okay. Let's go to diabetic patient, well managed, and all of a sudden they develop some disease that you would typically use corticosteroids for. Let's talk about cataracts first. So has anybody managed to gone to surgery for cataracts? All of you are in referral.
I don't think I have actually had one that's like I've been managing as it went to surgery. I've had one that before and after, but yeah, never actually at a time.
I haven't managed it, but I've seen it.
Seen it.
Other people,
Yeah. So in what situations would they use, or what form of cortisone do they use in cataract surgery? Like it's not, you're not using
topical,
yeah,
like prednisolone forte kind of thing.
Yes, exactly. So prednisolone forte is the most commonly used eye drop in the perioperative period. So often to decrease inflammation caused by the cataract itself, makes the cataract surgery more successful. Definitely indicated improved outcomes with pred forte as opposed to non-steroidal anti-inflammatory drops, to my understanding. But refer to Paul on that one, or any other ophthalmologist of your choosing. But we definitely see them in the perioperative period with the diabetes control getting a little bit haywire. And again, this is my opinion. and there's actually sort of studies saying that that doesn't happen in the veterinary literature.
And Oxford journals though, probably.
Yes. And the ophthalmologist will quote them to you when you're saying, we need to get this dog off the pred fort. And they're saying, no, we don't. But looking at the evidence that I've had access to, and I don't look at a lot of ophthalmology journals, but like there's a study with 22 dogs and they were randomly allocated either a non-steroidal or pred fort. You can't draw conclusions from 10 or 11 dogs. And they sort of said, you know, the outcomes were no different. The diabetes, like fructosamine levels, weren't significantly higher in the pred fort dogs as opposed to the non-steroidal dogs in the perioperative period. But certainly my experience, and any medicine specialist will be like, yes, like pred fort impacts their diabetes management. And in the human, like handout in the box, it says contraindications for medication, any disease associated with hyperglycemia, i.e. diabetes. Yeah. So certainly acknowledged in the human world. So I feel like in that situation, we're quite often managing like this idea that the diabetes should be well controlled and the cataracts like in the perioperative period. But I think it just helps to have that little bit of background to say to the clients, look, while we're on this medication, we're just going to aim for maintenance and like sort of limited control. We might have to mess with the insulin dose a little bit as we kind of go reduce the amount of drops that the dog's on. But you know, you've just paid $13,000 for eye surgery. Let's make sure that that sticks and deal with the diabetes once it comes off.
Right, so you may adjust insulin if you need to.
Yeah.
You can just control clinical signs.
Yes, exactly. Yeah. In dogs, I don't like to adjust insulin very often. So I usually do sort of 5 days or so before I'll 3 to 5, unless they're hypo, in which case I'll adjust faster. But yeah, these are good ones, I think, to have a sensor on around when they start the pred fort, and you can sort of say, yeah, see how the glucose has gone up a little bit. Let's just up the insulin a little bit to offset that. And then we'll put another sensor on when we're going to stop the drops and drop the insulin in response to that. Okay, you have a 9-year-old male neutered staffy who presents with pyrexia and ecchymoses over his abdominal skin and a platelet count of 4. And he is a long-term stable diabetic who has been managed on can insulin BID. What are you going to do?
Cry.
Uh-huh.
Goodbye to diabetic control.
Correct answer, Pooja. Correct answer.
Yeah.
First cry, then deal with it.
Yeah, exactly.
That's gonna be a mess.
Yeah.
You could definitely have indications for starting on steroid-sparing drugs at the beginning, but you do need steroids at the beginning too, because they work so quickly.
Yeah.
That's probably what I do as well. Go cyclosporin concurrently.
Yeah, good. There's a study that I think it was like 17 dogs. So again, I'm not sure we can draw conclusions from it, but they had dogs that were like on non-steroidals at the time of diagnosis. So like prednisolone was contraindicated, and they used mycophenolate as the first line single agent management of IMT with reasonable success. Yeah, but those are dogs that got unlimited transfusions until the mycophenolate kicked in, kind of thing. So that's maybe a slightly different story than the populations that we typically see. But that's maybe an option. But I agree with you in this situation, diabetes management out the window. We're just going to say we're going to do a solid 2 weeks on a high dose of pred, and the diabetes is going to go haywire. But completely agree, starting another immunosuppressant at the same time is very much indicated, and cyclosporin would be a perfect choice, as mycophenolate's fine as well. Azathioprine, I think, probably maybe a little bit too slow in onset, but also not a bad choice. The only thing with azathioprine is it causes pancreatitis. Maybe we should avoid that in this patient. We've talked about immunosuppressants before. Why is PRED so important in that early phase relative to the other immunosuppressants as far as their mechanism of actions go?
It's just it is, and you get a quicker response, but I think it's more to do with like the like lymphocyte inhibition.
Yeah.
Which is super important for stopping those, I guess, antibodies.
Yeah. So I think that PRED and all of the other ones are really good at cytokine inhibition, and therefore that antibody production mechanism. The advantage of PRED in that first kind of 5 days, because like if you sort of stop cytokines, you start mycophenolate or cyclophosphamide, you stop the cytokines that ramp up the immunoglobulin production on the spot, but the cytokines that have already been produced are already out and in circulation, and the antibodies that have already been produced are already out and in circulation. You have to wait till they drop off before you'll get any effect from that drug, so that the drug effect is immediate in terms of stopping cytokine production, but the antibodies, like the actual kind of benefit to disease, will be like over here once the antibodies have gone out of the system. So the advantage of PRED with most of the hematologic autoimmune diseases is that it actually decreases activity of the reticuloendothelial system. So you got decreased macrophage activity. So even though the platelets or red cells, whichever immunologic disease you have, are coated with antibodies, you'll get less destruction of them in that initial 5-day period while you wait for the other drugs to kick 2 to 5 days for the other drugs to kick in. Does that make sense? And there's obviously PRED has a lot of other activities in terms of cytokines, inflammation, blah, blah, blah. But that's kind of the main reason why it's so good in acute disease, and why we just say don't delay starting PRED. If you've got an IMHA patient, get a blood sample and start them on PRED. Good. What about, we've got a 10-year-old cat with long-term diabetes, which is well managed, who presents with acute onset respiratory distress, and a history of chronic intermittent coughing and wheezing, but presents with acute respiratory distress. What's our leading differential?
Feline lower airway disease.
Yeah, chronic bronchitis.
Feline asthma.
Yeah, I think probably it's a little bit of an older presentation for asthma, but it's a lifelong disease. So if we've got a cat with asthma who's diabetic, how are we going to manage the asthma?
I think in the initial period would use this and then put them on inhalers, like start the inhalers in a week or so once it's controlled. Dyspnea is controlled because the first focus is dyspnea.
Yeah, exactly. So if it's an emergency presentation, then decreasing inflammation in the lungs is vital if they're not oxygenating well. And when you've got bronchospasm, you can't get inhaled anti-inflammatories down into the areas that are really inflamed because the bronchi are closed. So which inhaled medications would you use?
So initially I'll just use, like the first presentation, if they're really dyspneic and oxygen dependent, then Dex, go with Dex, and then once they can tolerate oral, then use PRED. But then eventually get them onto fluticasone, Seretide or something like that.
And any others?
Terbutaline as like in the emergency setting, and then probably move to salbutamol inhaler for a short term, and put them off it.
Okay, so we want to do everything we can to open up the bronchi to make our inhaled corticosteroids more effective. So pairing fluticasone with a beta agonist. Agonist? Yeah. Yeah, because it causes tachycardia. It's an agonist. Yeah.
Agonist.
Yeah. God, so rusty. Yes. So using both of them. Are inhaled corticosteroids, do they impact the pituitary adrenal axis? Like how much is absorbed systemically?
I would think not very much, but I think there's some.
Yeah, it's quite a lot.
Is it?
Yeah, so we quite often have dogs with elevated ALP or whatever who are on inhaled, dogs in particular, but on inhaled corticosteroids that develop elevated ALP, and you do an ultrasound and their adrenals are tiny, and their ACTH stims are like Addisonian essentially because it's pituitary adrenal axis. So they did like radioisotope studies or something looking at how much was absorbed. I think Fleen was actually involved in them. Josh, if you can find out more about it.
Ask her.
But again, all small studies and we don't have great evidence, but certainly clinically, I've seen patients on inhaled corticosteroids have really poorly controlled diabetes and the sort of symptoms of Cushing's due to exogenous steroid exposure. Remember Buster Corbett?
Oh my God, I was going to say that, but I'm like, I don't know whether I should say that.
This dog had terrible
Still
Cushing
going.
signs. Still going?
Yeah.
Jeez.
I've been jigging his, he's a dog with Addison's, but also has chronic bronchitis. And he's on systemic pred, but also a fluticasone inhaler. But trying to juggle that because he's got all these kind of Cushing signs. And so I'm trying to like drop the pred as much as I can, but then use the fluticasone where I can, but he still has all these Cushing signs. It's quite tricky.
Yeah, this is a dog that like really significant quality of life issues from just before he was on pred, from fluticasone alone due to pot belliness and muscle atrophy in the hind limbs.
He's thriving now at the moment.
I think under your care. Phew.
No, it was the same.
All right, what about last one, anaphylaxis? Are we going to use a corticosteroid if we have a patient presented with anaphylaxis who's diabetic?
Well, you definitely want to use adrenaline if it's indicated. I don't know if corticosteroid is necessarily indicated in that situation.
Yeah, it's interesting. I think there was a study that showed that it didn't change the outcome fairly recently. But the reason I put anaphylaxis on my list to talk about is that we're compromising diabetic management for probably 48 hours. When these dogs have this, like, we're using adrenaline, it's going to, like, you know, it's a gluconeogen, and what is it? Counter-regulatory hormone for insulin. Anyway, this dog's going to have increased stress. It's going to have increased cortisol levels. Diabetic management out the window in an acute presentation where you feel like DEX is essential. Like if you're really suspicious of IMHA or something, sometimes just throwing diabetes out the window for 3 days is appropriate if you're looking at very short-term management. I don't actually know if DEX is used in anaphylaxis anymore, but a lot of people still do. Like because it's a CPR updates all the time, and I can't keep up with them. But it would be completely acceptable and well evidenced to use DEX if you did that. But I don't think it would be contraindicated in a diabetic patient, but maybe I'd look at the literature if I had a diabetic patient there. All right, we might wrap up. I have no idea what it is next time, sorry. But we'll see you in 2 weeks. Oh, I do know, it's obesity and the comorbidities associated with obesity. So we're going to go pretty deep on fat metabolism and cholesterol generation and excretion, and the comorbidities which are associated with obesity.
Great.
Right.
Thank you.
Thanks so much.
everyone.
Thanks, Anna. Bye.
Have a good day.